It's a great pleasure to introduce the next speaker. Helen Danish-Meyer is the first female professor of ophthalmology in New Zealand and is the Sir William and Lady Stevenson Chair in Ophthalmology, as well as being head of the academic neuro-ophthalmology and glaucoma section. She was the youngest appointed professor at the University of Auckland School of Medicine and one of the very few who's a professor in a surgical specialty. Helen is a clinician scientist and she divides her time between patient care, surgery and research. She has published more than 200 papers in glaucoma and neuro-ophthalmology, authored several textbooks and generated more than $15 million in grants. Several research findings have impacted clinical practice and her research has been featured in The New Scientist. She has already mentored more than 20 clinical and research fellows. She is very active in teaching, education, nationally and internationally, as you will all know. Her clinical expertise includes imaging modalities in neuro-ophthalmology, giant cell arteritis, ischemic optic neuropathies, the role of astrocytes in optic neuropathies, and of course, glaucomatous optic neuropathy. Several aspects of her research have influenced and altered clinical management strategies in the international arena, in particular her work on imaging of the retinal nerve fibre layer and chiasmal compression. As a neuro-ophthalmologist, she pioneered quantitative evaluation of the optic nerve and its morphological changes using many optic nerve imaging modalities such as OCT. Over the last 20 years, Helen has established a basic science research unit which investigates mechanisms of injury and repair in the optic nerve head and retina. In particular, research focuses on the temporal and spatial aspects of changes in connexin 43, a gap junction protein following injury. This body of work has identified new therapeutic strategies to modulate connexin 43 in terms of upregulation to enable neuronal rescue. Helen has achieved numerous firsts, many of which you will know about, but particularly many firsts for New Zealand ophthalmology. Being the first New Zealand member of the International Glaucoma Research Society, the first New Zealand ophthalmologist to be visiting professor at Harvard Fall Festival, the first Kiwi or Australian to be appointed to the American Academy of Ophthalmology Basic Science course, and of course being the first to serve on the editorial boards of both the American Journal of Ophthalmology and Ophthalmology. However, Helen is also a very active contributor to the wider community. She is the only New Zealand ophthalmologist to ever been awarded the Paul Haas Award by Rotary for her many, many contributions to the community. These contributions include being the founding trustee and chair of Glaucoma New Zealand, a 15,000-member charity set up to prevent blindness from glaucoma. She is also presently the chair of Women in Ophthalmology for RANSCO. We may hear a little about that. Helen is a loving parent with Mike, her husband, to her two gifted daughters, Juliet and Emily, who are here today and following their parents' direction into the medical profession. It's no wonder with all these achievements that in 2022, Helen Danish-Meyer was ranked by the Ophthalmologist magazine as one of the top 100 most influential people in the world of ophthalmology. She is undoubtedly a most deserving awardee of the Ida Mann Memorial Lecture here today in Brisbane. I give you Helen Danish-Meyer.
Thank you, Charles, for that very kind introduction. It truly is my privilege to deliver the 2022 Ida Mann Lecture. Dame Ida Carolyn Mann was a petite woman who was truly larger than life, and in many ways, decades ahead of her time. And she is without doubt the grand lady of 20th century ophthalmology, a remarkable individual, thinker, clinician, and scientist. Dame Ida made her mark early in life in a world unprepared for brilliant and ambitious women. She fought against social convention and family disapproval to study medicine. She blazed a pioneering trail, accumulating many first-ever achievements. For example, she was the first woman ophthalmologist elected a Fellow of the Royal College of Surgeons. She was the first woman appointed senior surgeon at Moorfields Eye Hospital. She was the first woman ophthalmologist to have a private practice on Harley Street. And she was the first woman to receive a personal professorship in any discipline at Oxford University. Among Ida's many personal qualities, perhaps three are most striking. First, she was a brilliant polymath. She mastered multiple diverse scientific disciplines ranging from embryology, toxicology, infectious disease. Outside of medicine, she was an accomplished novelist and painter. Second, she was supremely confident. She was outspoken and did not suffer fools. She allowed herself no concession for being a woman. When appointed to an important role, she said, "It was simply that I had the best qualifications for the job." Third, she was effervescent and had a great zest for life. On one occasion, when invited to a stodgy London banquet where ladies typically wore fur neck pieces, Ida sprung a surprise. She wore her pet boa constrictor around her neck, after suitably immobilizing it by prior refrigeration, of course. When asked why she did this, she just smirked and said, "Just to see what the other ladies would do." As well as her daring personal example, Ida left another valuable legacy, her way of thinking about the eye. After immigrating with her husband to Australia in 1949, Ida began investigating trachoma among Aborigines in Northern Australia. Anticipating several of today's pressing concerns, Ida identified the link between disease and multiple external risk factors, culminating in her 1966 landmark book, Culture, Race, Climate, and Eye Disease. This focus on the links between the eye and the external world complemented Ida's earlier work. In her pioneering studies in embryology, Ida identified the shared origins of the eye and the brain, namely that the retina and optic nerve extend from the diencephalon during development. This fundamental observation laid the foundation for a revolutionary new approach in clinical neuroscience that is the overarching theme of my lecture. That is, the eye can serve as an accessible source of powerful insight into the brain. Because of the shared origins of the eye and the brain, retinal ganglion cells and the optic nerve share common features with CNS neurons, such as being surrounded by meninges, a blood-brain barrier, and glial neuronal syncytia, among others. In other words, the optic nerve is the back of the eye, but it is also the front of the brain. Indeed, today it would seem a misnomer to call the optic nerve nerve. By contrast, optic CNS white matter tract would appear to be more accurate, although the renaming may strike a raw nerve with some. During the remainder of this talk, I will draw on my team's research to help illustrate three key aspects of the emerging understanding of eye-brain linkages. I will focus on disease diagnosis, prognosis, and dynamic injury. A recurring theme in the journey from Ida Mann's discovery to today's clinical insights has been the close interplay between advances in technology and major translational leaps in clinical practice. As early as 1986, a team led by Carol Miller at the University of Southern California undertook a postmortem study in patients with Alzheimer's disease and observed that 8 of their 10 samples demonstrated varying levels of optic nerve degeneration. However, due to the study's very small sample size and limited postmortem histological methods, determining the relevance of this observation had to wait 20 years when in 2006, our group reported the first study on this topic in living patients. We started the efforts a few years earlier with the Heidelberg retinal tomograph, which some of you may recognize, a scanning laser ophthalmoscope. At the time, the HRT was the only technology available that could quantitatively image the optic nerve, and I had been using it in glaucoma as part of my fellowship at Wills. We correlated optic nerve measurements and retinal nerve fiber layer with cognitive function and risk of Alzheimer's disease in 90 participants. Our study found a clear dose-response relationship between optic nerve head thinning and lower cognitive function, including a threefold excess of Alzheimer's disease in patients with extreme thinning. Importantly, this was in the absence of any measurable optic nerve visual dysfunction. Our work, therefore, helped establish the concept of the ability of the optic nerve biomarkers to give insight into CNS injury. But our work also raised new questions, as noted by Neil Miller of Wilmer Eye Institute in his editorial that accompanied our paper. He asked whether future advances in technology would support the clinical translation of our findings, given the inherent limitations of the HRT, which was not ready for prime time, as he called it. The answer was yes. More than a decade after the publication of our group's results, a team led from Moorfields Eye Hospital combined OCT and serial cognitive testing in over 32,000 participants in the UK Biobank population study. Their findings confirmed our observations. Thinner retinal nerve fibers were associated with worse cognitive function, but they also made an additional intriguing observation. Retinal nerve fiber layer thinning is associated with a doubling of risk of future cognitive decline. Further research from my team and others has generalized these observations, showing that the link between the optic nerve biomarkers and cognitive decline are not an isolated example. Accumulating data also show that ocular biomarkers are an indicator of a wide range of neurodegenerative diseases. For example, in the first report to correlate OCT measurements in patients with Huntington's disease, Dr. Hannah Kirsten, a PhD student at the time in my group, found that temporal thinning of the retinal nerve fiber layer, as well as macular volume, were associated with higher risk of Huntington's disease, as well as greater disease severity. Such findings will be useful in clinical trials of novel agents in neurodegenerative conditions and have already been incorporated into some of these trials. More generally, as summarized in our paper in Lancet Neurology, multimodal imaging of the optic nerve is advancing the diagnosis and management of patients with a range of neuroocular conditions. A grand challenge during the coming years will be to identify imaging and other biomarker signatures that are specific to neuroocular conditions. While the assessment of the optic nerve has been revolutionized by technological advances, the clinician's finger remains our state-of-the-art tool for examining the efferent system. In principle, however, images from the efferent visual system can provide powerful and rapid insight into brain function. As MRI techniques such as diffusion tensor imaging have demonstrated, the execution of eye movements involves integration of a complex and vast network of white matter tracts. Although eye tracking has been around for 50 years, it has typically comprised of large, laboratory-based machines with scleral coils, bite bars, and chin rests. Curiously, patients seem to be reluctant to embrace these methods. By contrast, recent advances in software and hardware technology have opened major new opportunities for examining the efferent visual system. Over the past 3 years, Dr. Matthew McDonald, a PhD student in my group, has built a state-of-the-art eye tracking system using 3D printed glasses. The device is compact and mobile. The eye tracker consists of a backward-facing pupil camera and a forward-facing world camera. The glasses are programmed to detect the laptop screen through the QR codes in each corner. This allows a patient's gaze to be mapped with high precision and accuracy. As part of his initial evaluation, Matthew has tackled the issue of concussion. He has worked with Matai Research Institute in Gisborne to recruit 40 high school rugby players who are part of the first and second 15. Players had tests at the beginning and the end of the season, as well as following any concussion. Each player also wore a mouthguard accelerometer, which would allow him to quantify the amount of force sustained to their heads throughout a season. Matthew correlated white matter tract abnormalities found on diffusion MRI to eye tracking metrics. Our initial results are striking. On the left is a normal tracing of a participant's smooth pursuit prior to concussion. The target that the patient is tracking is pink, and the patient's eye is represented by the small green circle, by the green circle. The patient is tracking the green circle with exquisite accuracy. Now on the right, you can see the contrast after concussion. You can see that smooth pursuit is not as smooth as the pink circle and green circle do not align. And this is an example of the tracing produced by the tracking. The top shows a normal tracing. However, the bottom tracing demonstrates microsaccadic intrusions invisible to the human eye, occurring in less than 20 milliseconds, but characteristic of concussion. These gives us a glimpse into the omnipause neuron function and the pathology that occurs with concussion. Given that the US National Institute of Health just this week acknowledged a causal link between concussion and chronic traumatic encephalopathy, such readily available tools for diagnosing and managing concussion are likely to play a major role both in amateur and professional sports in years to come. Therefore, it seems that the eye can provide insight into the diagnosis of brain injury. However, there's also evidence to suggest that the eye has a role in prognosis. Early suggestions that the eye could help predict the trajectory of brain disease comes from simple anatomical inferences. At the annual meeting of the American Academy of Medical Association in 1895, for example, James Linston waxed lyrical. The semidecussation of the optic nerve seems to have been designed by nature, among her all-wise provisions, as a means of creating a more intimate relationship between the eye and the brain. Linston's argument was given empiric support almost 80 years later. In 1976, two Swedish ophthalmologists, Mats Lindström and Lars Frizon, made an initially little-known discovery linking the eye and the brain that was to have profound implications for disease prognosis. By careful observation of fundus photographs, they noted the characteristic band atrophy in patients with chiasmal damage. 30 years elapsed between the Swedes' scientific findings and the advent of new technology so that this observation could become clinically actionable. In 2006, together with collaborators from Wills Eye Hospital and Peter Savino, we reported the first study to compare structure-function correlation of retinal nerve fiber layer thinning in patients with chiasmal compression, taking advantage of the newly available OCT at the time. We found that temporal and nasal quadrants showed thinning of nearly 50% in patients with complete bitemporal hemianopias. Here's a fundus photograph of a patient with bitemporal hemianopia with what appears to be subtle band atrophy. By contrast with the OCT, the finding is unmistakable. There are few scenarios as intellectually satisfying as observing such a perfectly harmonious correlation of form and function as a bitemporal defect with band atrophy. No wonder as neuro-ophthalmologists we often end up admiring disease rather than treating it. In some patients, however, as you can see from this example, there's a glaring mismatch. We have a normal appearing OCT and a dense bitemporal defect. Journal reviewers and editors were confused, interpreting this mismatch as poor scan technique, or that the OCT is good for glaucoma, but perhaps not for other optic neuropathies. But I always tell my fellows, a rejection letter from an editor is an invitation for negotiation. So the negotiation started. Rather than interpreting our results as artifacts, we believe the mismatch told a meaningful biological story, something essential about the nature of compressive optic neuropathies. We hypothesized that our findings demonstrated that compression at the chiasm was analogous to one's arm falling asleep, and after sitting on it for a period of time. Function was lost, but structure remained intact. So if we freed the compression, such as with pituitary surgery, the function should improve. To us, this interpretation explained why the OCT was measuring a normal retinal nerve fiber layer and the presence of a complete bitemporal loss. Along with neurosurgeons in Auckland and at Wills Eye Hospital, we designed a prospective study to test the idea and find out if OCT could predict recovery of vision following chiasmal compression. Remarkably, we found that the degree of recovery of visual dysfunction was related to the thickness of the retinal nerve fiber layer as a measure of OCT. We had identified a biomarker that predicted degree of visual recovery after surgical intervention. In particular, patients with a complete bitemporal defect who had recovery of greater than 10 decibels had an OCT thickness of greater than 75 micrometers. To investigate the temporal pattern of visual recovery following pituitary tumor resection in eyes with and without preoperative RNFL thinning, we then conducted a 10-year prospective study of 230 patients in collaboration with the neurosurgical department at the University of Melbourne. We found that eyes with normal retinal nerve fiber layer thickness at baseline experienced most of the recovery within the first 6 weeks. However, eyes with a thin RNFL had whatever recovery they were going to have at a much slower rate. We have subsequently extended this work and developed a multivariable risk prediction model, which has now been widely adopted for patients' counseling and prognostication, making a real-world impact. So far my talk is focused on how advances in imaging have allowed visibility of detail previously invisible to the naked eye. But there is another invisible world to be visualized, and that is of tiny motion. Our assumption about etiology of disease has been dominated by what we see in static 3D, because of course that is what available technology can resolve. But perhaps this paradigm needs to be challenged. Developed by scientists at MIT, tools have now recently emerged to help visualize tiny variations, resulting in what can be called motion microscopes. Drawing on a branch of mathematics founded by the 18th century Swiss mathematician Leonhard Euler, who we now have tools to see the brain in motion. Eulerian magnification relies on computation rather than optics, and it is already having an impact on biology, structural analysis, and mechanical engineering. And as I'll discuss briefly here, it is poised to make a major contribution to clinical neuroscience. So let's see what type of magnification of motion is produced. On this slide, you see a video of a person not magnified on the left, and on the right, you can see the subtle movements that are occurring that are invisible to us when we look at her. So how can we use this ability to amplify motion to study the brain? My colleague, Dr. Samantha Holdsworth from Stanford, a brilliant medical physicist, has recently taken this technology and applied it to MRI to create a new imaging processing tool called Amplified MRI, which we have just started to use to study eye-brain connections. Here's an example of its output. The brain on the left is the video with the standard MRI technique, while the image on the right is an amplified movement of the brain in normal motion. Our initial focus is to develop a non-invasive technique to measure intracranial pressure, and we are working towards being able to incorporate a 4-minute amplified MRI sequence that will accurately estimate intracranial pressure. In this 3D reconstruction, we have used AMRI to create motion maps of brain deformation in response to a range of physiological dynamics. Motion maps from patients pre- and post-lumbar puncture are allowing us to build a computational model that predicts brain pressure. We are also using this technology to help understand how microscopic movements impact different eye and brain diseases. Here's an example of a patient with Arnold-Chiari malformation, a condition in which the cerebellum prolapses below the foramen magnum. Note the piston-like movements of the spinal cord, which may actually explain why these patients develop a syrinx, and we haven't understood why this has occurred previously. However, another critical interface where the eye and the brain engage is the lamina cribrosa at the back of the globe. This 400-micron thick membrane separates two pressure compartments, the intraocular pressure and the intracranial pressure. This is known as the translaminar pressure gradient. Like the neck of a rugby hooker in a scrum, the lamina cribrosa is the site where two opposing forces collide. Fortunately, the lamina is more stable than most rugby front rows nowadays, especially the Wallabies one. Two conditions where the translaminar pressure gradient plays a significant role are glaucoma and idiopathic intracranial hypertension, which we can consider glaucoma of the brain. In glaucoma, the IOP is greater than the ICP, and we see posterior bowing of the lamina cribrosa. while in IIH, glaucoma of the brain, the higher intracranial pressure results in a forward displacement of the lamina in papilledema. We are applying amplified MRI to both these conditions, and I would like to share some of our early preliminary unpublished data. Following lumbar puncture, there is an increased free movement of the brain, particularly in the brainstem area, in patients with IIH. This is not what we predicted, but this raises the question of whether this restricted movement of brain contributes to the symptoms of headache in patients with IIH prior to LP. In the orbit, there are 3 interesting observations post-lumbar puncture. First, the optic nerve sheath diameter is visibly smaller post-LP. Second, the sheath is more collapsible. And third, the entire optic nerve seems more mobile in the orbit following lumbar puncture. So what happens in glaucoma? In the brain, it appears there's no significant difference between pre and post-IOP, but we need to recruit a few more patients to confirm this. However, in the orbit, there seems some intriguing observations. This patient had an IOP of 27 millimeters of mercury prior to treatment, and then we applied latanoprost and brimonidine to lower the IOP to 15. First, notice that the pre-treatment eye with high pressure shows a significant greater anterior-posterior movement. Second, in contrast to IIH, the diameter of the sheath is greater after drops. We are still to unravel the full implications of these findings, so watch this space. So what is the relationship between the eye and the brain? Like most relationships, it's complicated. My overarching assessment is that there is clearly an intimate interplay between the eye and the brain that we are only beginning to appreciate. I believe this interplay is a relationship that stems from the common embryological origins and extends to include late-stage neurodegenerative diseases, and is likely to have a clinical role in diagnosis, prognosis, and management. In this brief survey, I've reviewed some major developments at the interface of the eye and the brain, all particularly inspired by Ida Mann's foundational insights made almost 100 years ago, and all made possible by advances in technology. And I'd like to finish by highlighting a specific dimension of Ida Mann's contribution that is instructive for researchers today: her approach to collaboration. Mobilizing her abundant talent, flair, and breadth, Ida created scientific collaborations with leading authorities worldwide across multiple fields, including legendary figures such as Sir Richard Dole, Nobel Prize-winning pathologist Howard Florey, biochemist Sir Hans Krebs, and Aboriginal activist Father Frank Flynn. As I have observed through my own research experiences, diverse collaborations enrich perspectives and help maximize the scope and impact of scientific discoveries. Visual science is increasingly a global team sport. Or in the words of Ida, we use research in order to answer the age-old question: what makes you get what you get, when you get, and why? And surely nothing could be more rewarding than that. Thank you.
An absolute brilliant Ida Mann lecture. We don't take any questions after Ida Mann, although I have some, Helen, but we'll do that later. There is a medal, and I was ferreting around trying to find a medal. Someone's stolen it. There is a medal, and I'm sure it's coming. But meantime, I'd like to say very many congratulations.
Thank you, Charles. Thank you.
Thank you.